So the way I've designed this talk is the first 17 slides are just real basics. And it's just to make sure that we're all on the same footing with definitions of disease. And then after that, I've got a bunch of slides to go over what I call hot topics. And we'll get through what we can. And if whatever I don't get through, I'll just save for another day. So I work in Seattle. I'm part of the what's now called Providence Swedish Medical Center. Used to be called just Swedish Medical Center. And then am also part of the larger Providence network. And I also do some teaching at the university. Providence, by the way, is all up and down the West Coast and extends out to Texas. So this first slide basically makes the point that there's a significant genetic and clinical association between the diseases that are listed here, including what you will soon come to learn is a term that's going to go out of fashion soon, and that's ankylosing spondylitis. And we'll talk about that in a second, as well as psoriatic arthritis. The arthritis is associated with inflammatory bowel disease, ulcerative colitis, or Crohn's disease, and the something called reactive arthritis, which it mainly occurs in second and third world or developing countries where there is more infectious stimulus to the development of spondyloarthritis, especially in HLA-B27 positive individuals. And then over on the right, this big circle that is psoriasis, which is the skin condition. And I'm going to speak to all of this in a moment. And uveitis is part of this collection of genetically associated conditions. What used to be called ankylosing spondylitis, we now called axial spondyloarthritis or radiographic axial spondyloarthritis, is depicted here. And it typically begins in a male's youth in their 20s and early 30s, and 2-to-1 male. It involves primarily the spine and sacroiliac joints at the base of the spine, but also can involve inflammation in peripheral joints and where tendons and ligaments insert into bone. The patient will have a history of occurring in a younger age inflammatory back pain. And the next slide, I'll teach us what that means. Typically good response or decent response to anti-inflammatories. And it's one of the most heritable diseases in rheumatology, often a family history. When we're doing physical exam, we look for evidence of pain where tendons insert into bone, like the Achilles tendon, or the knee or other peripheral joints. And we also look for evidence of extra articular features such as uveitis, inflammatory bowel disease, or psoriasis. In the laboratory, it's pretty straightforward and simple. It's just looking for the gene marker HLA-B27, which is positive in about 85% of patients, but 15% is negative. And then a inflammation marker, CRP or sed rate. The key for us is imaging, and especially MRI imaging, to identify whether there is inflammation in the sacroiliac joints and spine. Here are the features of inflammatory back pain. Age and onset of less than 40 years of age, insidious rather than sudden onset, like a back injury would be sudden, as opposed to axial SPA. Improvement with exercise, no improvement with rest, and pain waking the person at night, leading to their getting up and walking about in order to relieve the pain. So if you have at least 3 of these 5 features, then you fulfill what we call inflammatory back pain criteria. I know that that said 4 out of 5, but it turns out that 3 out of 5 is also sensitive and specific. So here is a set of images that teach us about this spectrum that we now recognize. And the spectrum includes patients on the left-hand side of the slide who may have a normal X-ray of their sacroiliac joints showing no joint space narrowing or irregularity of the joint. And on MRI scan may light up because inflammation is present in the bone adjacent to the sacroiliac joints. Or in the very lower left, an MRI negative patient, that is someone who doesn't have evidence of inflammation in the spine or SI joints, but happens to be HLA-B27 gene marker positive and has other features of spondyloarthritis. And then to the right, we're seeing more definitive evidence of radiographic X-ray, not MRI, X-ray changes of either sacroiliitis or spine disease. And when we were limited years ago to only looking at X-rays, it took us a long time to make this diagnosis because the X-ray changes are glacial. They take years to develop oftentimes. And in many women, they don't ever develop. Women are protected from having these types of X-ray changes. And so this is a kind of a schematic which speaks to the fact that over the decades, a person starting with inflammatory back pain will develop non-radiographic axial SPA, and then later on, radiographic evidence of radiographic axial SPA. But some people, in fact, about half, will remain always non-radiographic. They won't have the characteristic changes on X-ray of the sacroiliac joints or spine. So this is also depicted here, and I've made the point down below that about 0.5% of the population has what we used to call radiographic axial SPA or ankylosing spondylitis, and then about a little over half of the population on the left-hand side, especially females, do not have this X-ray evidence. Now, here's a slide that teaches us that, so when we do our taking care of patients, whether it's in the clinic or in the hospital, and we put in the electronic record, our diagnosis code of what we're seeing the person for that day, high blood pressure, diabetes, psoriatic arthritis, axial spondyloarthritis. We put in what happens in the electronic record is that it's populated by these numbers that are part of the ICD system, the International Coding of Disease System. And this is how we identify for billing purposes or insurance or classification in the EMR what the patient has. And in our current ICD-10, which has been present since 2016, we have the term ankylosing spondylitis there, but also this term non-radiographic axial SPA. Note that as we move into the future, into ICD-11, which is not with us yet, but will be in the next few years, where's the term ankylosing spondylitis? It goes away. It doesn't show up anymore. And this reflects the fact that we are now diagnosing so many people beyond this ankylosis group, the ankylose group. And so the specialists and researchers in this disease have wanted to broaden the term to axial, which just simply refers to spine, but doesn't bring up the ankylosing part of it. That's a meaningful portion, and probably several of you have ankylosis, but not necessarily. And so that's why the name change is occurring. Just a few words about treatment. Our options are somewhat limited. We really encourage physical therapy. We encourage anti-inflammatories if tolerated, such as Aleve or ibuprofen or Celebrex or meloxicam. And then in terms of the biologic immune moderating medicines, it's really very limited. There are the 5 TNF inhibitors, the currently 2 interleukin-17 inhibitors, Taltz and Cosentyx, and there's a new one coming next month, which is called Bimzelx, or I know it as bimekizumab, which is an IL-17A and IL-17F inhibitor. And then the class we call Janus kinase inhibitors or JAK inhibitors, which include Xeljanz and Rinvoq. Just a quick word. This is a paperback copy of a textbook, which Asim Khan, a really important figure in the world of ankylosing spondylitis research, has, and I co-edited. And if any of you all ever want to go on Amazon, this is a reasonably up-to-date textbook which covers the subject. Now I'm going to shift to psoriatic arthritis. And I like to show this slide because it gets across the point that in addition to the spine, which you can see on the far right, and the sacroiliac joints, and arthritis, which you see in the upper middle part of the slide, it has a bunch of other things going on, including skin disease of psoriasis, noted on the left here, nail disease, which is characterized here. Here's more of the skin disease of psoriasis. And then arthritis in the top middle here. This heel X-ray is intended to demonstrate enthesitis, which is inflammation where the plantar fascia inserts into the heel bone or the Achilles tendon inserts into the heel bone. And then what we call dactylitis, swelling of a whole digit, which involves not only arthritis and enthesitis, but also osteitis of the bone. And then here we have the associated conditions of inflammatory bowel disease, uveitis, and then this poor woman who is obese, has psoriasis, psoriatic arthritis, and likely she has hypertension and elevated cholesterol, and is struggling to prevent cardiovascular disease from occurring early in her case. And this just is a quick picture from one of Chris Richland's New England Journal articles, which shows the different molecular markers of pro-inflammation molecules like interleukin-17 and 23, or TNF, which are involved with inflammation in these sites, as well as various cells. I'm going to skip to this, which is, we know that psoriasis occurs in about 3% of the US population. We know that psoriatic arthritis occurs in up to 30% of people with psoriasis, as low as 10%. And this yields a prevalence of psoriatic arthritis of somewhere between 0.3 and 1% of the US population, fairly similar to the frequency of rheumatoid arthritis and not too far off from the frequency of axial spondyloarthritis. Here's a listing of the medications that are used in psoriatic arthritis treatment. I'm not going to go through any of these in detail, but just I'm going to highlight a couple of the newer ones that have come along, and then just so you can reflect on which ones of these you may have tried already. So, for example, in the TNF inhibitor class, these are the generic names. The trade names are Enbrel, Remicade, Humira, Simponi, and Cimzia. You may recognize them from those names. And then there are various biosimilars to both infliximab and adalimumab that are now on the market. I think there's something like 8 or 9 different biosimilar or generics for Humira at the moment. Here is the GRAPPA treatment guidelines. GRAPPA stands for Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. It's a association of about 1,000 people that are either rheumatologists or dermatologists spread all over the world. Some of them doing research and education, all of them taking care of patients, and have a special interest in psoriatic arthritis. And we come out with these treatment guidelines periodically. And you'll notice that in most of these boxes for the different clinical domains of the disease, most of the medicines are listed that I showed you on the previous slide. However, in the spine department, we'd have fewer medicines listed there. And this is partly because we don't have as much clinical evidence for efficacy of some of the medicines that work well in the peripheral joints or the enthesium. I'm going to mention a little bit more about this in a moment. So let's get right into it. Is there a difference between the spine involvement in psoriatic arthritis and the spine involvement in someone without psoriasis who has pure axial spondyloarthritis? Here we have a patient who stooped forward, has spine disease as evidenced by X-ray, and has psoriasis lesions on his legs. So this would be a person who has the axial component of psoriatic arthritis. So in contradistinction to axial spondyloarthritis, where many people have their start of the disease in their late 20s, early 30s, in psoriatic arthritis, the spine disease tends to come on later in late 30s, 40s, 50s, or even later than that. So it's often hard to tell whether the person is having back pain from psoriatic arthritis or back pain from gradually progressive degenerative arthritis that occurs in all of us in the spine over time. There's some shared genetics. About 85% of people with axial spondyloarthritis or AxSpA have a B27 positivity, whereas only about 30% of people with psoriatic arthritis do. And then there are other genetic differences between people with axial PsA and ankylosing spondylitis. And the clinical differences, the patient may not even complain of back pain, yet have evidence of it on imaging. They may only complain of pain in their neck and not in their sacroiliac joints or lower spine. So there are some key differences between the conditions clinically. Here's a person with axial psoriatic arthritis who, where it says 3, that's a sacroiliac joint that is narrowed, irregular, quite involved with arthritis. But on the side that says 0, there's no evidence of disease in their sacroiliac joint. So asymmetric involvement of these joints. And then here on this lateral view of the X-ray of the spine, down toward the bottom, the big arrow is pointing toward what we call chunky syndesmophytes. These are calcium bridges between the vertebrae that are very different in appearance than the appearance of those of ankylosing spondylitis. And that's shown here again with spotty changes in PsA as opposed to the almost bamboo spine we see in AS that's very advanced. I mentioned earlier that there's a shorter list of drugs for the spine. We've seen good evidence for benefit on the spine for TNF inhibitors, interleukin-17 inhibitors, and JAK inhibitors. But it's uncertain about interleukin-23 inhibitors, which work really well in the skin, in the joints, in the entheses peripherally, in inflammatory bowel disease, but we're uncertain about the spine. And part of that is based on this study with the drug Skyrizi or risankizumab, an interleukin-23 inhibitor. In a small study in ankylosing spondylitis, it showed no difference from placebo. and so appears not to work in that disease. But then there was a study with the other interleukin-23 inhibitor known as guselkumab or Tremfya, where we looked carefully at about 30% of the patients that were in the phase 3 studies with this drug in psoriatic arthritis, and who the investigator thought had axial component to their disease and had changes in their sacroiliac joints, and they benefited from this drug. So this led us to think maybe there's enough difference between axial psoriatic arthritis and ankylosing spondylitis that the evidence that we see for drug benefit in ankylosing spondylitis may not apply to axial PsA. And so there's a separate study dedicated just to the spine disease of psoriatic arthritis patients. Over 400 patients are going to be admitted into the study where this drug is being tested to give us more definitive evidence about that. Now I'm going to just mention a couple of new therapies that are there. I'm starting with a therapy that's already there as a shot that you give yourself subcutaneously. This is data on the drug secukinumab, also known as Cosentyx. It's approved for both axial spondyloarthritis, both ankylosing spondylitis and non-radiographic axial SpA, as well as psoriatic arthritis and psoriasis. Now, one of the things that we know is that if a person has Medicare, their cost for medications is lower if they get drugs as an intravenous administration as opposed to a subcutaneous administration. Medicare, in its wisdom, handles subcutaneous and IV medicines differently. And so it was important, since we only had 2 intravenous drugs approved for psoriatic arthritis and axial SpA, which are golimumab or Simponi and infliximab or Remicade. Historically, we now have an IL-17 inhibitor that's available intravenously, which should make it easier on Medicare patients' cost. There's a new IL-17 inhibitor that's due to be approved within the next month by the FDA. It's already approved for the treatment of psoriasis. It's called bimekizumab or Bimzelx. And here is data from a psoriatic arthritis trial that shows that it works very, very, very well in treating psoriatic arthritis. And there are similar studies in both radiographic axial SpA or ankylosing spondylitis and non-radiographic axial SpA that shows it works really better. And in some instances, some of the measures possibly even better than the IL-17A inhibitors, Cosentyx and Taltz. So this adds a little broader inhibition of the interleukin-17 family. There's long-term data with guselkumab and risankizumab, that's Tremfya and Skyrizi, that shows good benefit for psoriatic arthritis. And here's a really pretty cartoon which shows how these drugs work. Right at the middle and the top of the slide, we see this sort of angry dendritic cell that's sitting right next to the intestinal wall. And it's sensing that the microbiome change that we know exists in ankylosing spondylitis and psoriatic arthritis is being sensed as a danger signal. And then it's spewing out interleukin-23, which travels to different places in the body, including the joints and the skin and the gut and so on, causing inflammation. And this is what is inhibited when we give a patient an interleukin-23 inhibitor. And here's some evidence of really long-term 100-month, 100-week data with the drug Tremfya. Oral medications. There's a drug that's been approved for psoriasis known as deucravacitinib, which is a TYK2 inhibitor. It's a little different than Xeljanz or Rinvoq, which are JAK1 and JAK2 inhibitors, and JAK3. And here is data from the phase 2 trial with deucravacitinib showing its efficacy in psoriatic arthritis. We don't have any data on its efficacy yet in ankylosing spondylitis, so that's an unknown. But this is a new once-a-day pill, which is going to be, it has been shown to be effective in psoriatic arthritis. And it's already been approved in psoriasis. We expect a formal approval in psoriatic arthritis in about a little over a year's time. Now, what we do if you happen to be a person who comes into the clinic, you've been with us for 10 years, and you have been on 5 different medicines, and you come in and you say, gee, my back pain is worse, or my Achilles tendon inflammation is worse, my skin is worse, what do we do? Is there another medicine that we haven't tried yet, or another class of medicine that we haven't tried? Of course, we're going to try to figure that out. But there's some strategies that we have been doing more recently. One of them is to intensify current treatment. And here is an example of a study in which Humira, instead of once every other week, was moved to once every week. And in the upper right-hand graph, we see that about 30% of the patients who did that maneuver, and we got insurance to cover going to weekly Humira from every other week, we were able to get better responses, more likely to be in a state of minimal disease activity. We're also now starting to play with use of 2 biologic treatments at the same time, or a biologic treatment and then an oral medicine like Rinvoq or Xeljanz. So here's an example of a group in Spain that collected their information about people that they were using dual therapy in, about 29 patients. Many of them had inflammatory bowel disease and either psoriatic arthritis or axial spondyloarthritis. And they were all in a state of either moderate or high disease activity. And then they went on this combination, and lo and behold, about 2/3 of them got into either remission or low disease activity for their spondyloarthritis manifestations. And there are various combinations that were used, like putting a TNF inhibitor together with an interleukin-23 inhibitor, or putting a TNF inhibitor together with an IL-17 inhibitor. And the way we do this in the clinic is ideally if we do it with another practitioner, ordering one of the medicines, and then we order one of the medicines. So working with gastroenterologist or dermatologist, that's one of the ways that we get around insurance companies coming back to us and saying, oh, no, you can't use 2 expensive medicines at the same time. They haven't been studied adequately together. Keep in mind that problems can occur, and in this group of 29 patients, there was one serious infection, and that is a Staphylococcus bacteria that caused sepsis. So that has to be kept in mind, that when we intensify treatment, we may also slightly more compromise our ability to fight off infections. Here's a formal study done by the Janssen group with their drugs Simponi and Tremfya. And they tested whether or not in the disease ulcerative colitis, there was benefit to putting these 2 drugs together. And indeed, in the gray box to the right, they were. Whereas the maroon and teal colored boxes were Simponi or Tremfya alone. The combination did better. And I won't get into this in any depth, but it was, if you look at the lower right-hand corner of this slide, what is being shown here is the improvement in inflammation genes that occurred during the course of this combination treatment, and it was magnitudes more benefit, reduction in the bad guy genes and improvement of the good guy genes when the two were used in combination. Just saying, in our clinic, we have at least 100 people that are on dual therapies at the moment. They typically tried at least 5 therapies previously, and we're using all kinds of combinations. The last thing I want to mention, and I'll try to do this, John and Jen, in about 5 minutes or so, is talk about obesity. And part of the inspiration for this comes with the fact that we have these new treatments specifically for being overweight. There are also treatments that are being used in diabetes, and I'll explain them in a moment. But they're medications that are very effective for improving obesity. Many of you may struggle with the fact that you're a bit overweight or significantly overweight, and you try as hard as you can with dietary approaches, just can't control that. We know that in psoriatic arthritis, obesity is there's a genetic proclivity to having obesity, 27% of patients. And it's not a matter of overeating all the time. It's a matter of the fact that your genes create more adipose tissue or lead to the creation of more adipose tissue. We also know that if you can lose weight, your psoriasis scores will improve. And if you can lose weight as a psoriasis patient and keep it low, that you're less likely to down the road develop psoriatic arthritis. We know that in 30% of patients, psoriatic arthritis will develop in patients with psoriasis. And this takes about 10 years on the average. If you're normal weight, you have less likelihood of that happening. And if you're normal weight as opposed to overweight, you're more likely to be able to achieve various treatment targets that we're aiming for when we use the various immune moderating medicines that we employ for treatment of psoriatic arthritis. Here are some examples of the new medicines that are available to us. For example, semaglutide, and it comes in 2 forms. One for treatment of, it's the same medicine, but it has 2 different names, Ozempic and Wegovy. So Ozempic is for diabetes, Wegovy is for weight loss. Go figure why they have the same medicine with 2 different names in 2 different packages. And these drugs, they're called GLP-1 agonist. And they do various things in both the endocrine system, in the gut, in the brain, to reduce appetite, to lead to reduction of food intake, to improve insulin biology, to slow gastric emptying. There's also now a dual agent, what's called a GIP, or glucose-dependent insulinotropic polypeptide. Say that rapidly. As well, and it's combined with a GLP-1 agonist, and it's called tirzepatide, and it has 2 names as well, Zepbound for weight loss and Mounjaro for diabetes. You all may have heard about these because there's a certain fad going on, especially in Hollywood, for people all over the place getting these medicines, which unfortunately are expensive. So as it turns out, and this just shows that it works, significant amounts of weight loss that occurs over the course of half a year. Now, and more so with this dual medicine, tirzepatide. Now we're learning that these medicines have immune moderating effects. They're receptors on various cells in our immune system, macrophages, lymphocytes, and so on. And in animal studies, we've got all kinds of things that have been shown. Lowering levels of TNF, interleukin-6, improvements of various inflammation markers, lowering of interleukin-17, interferon. So there are important immunologic effects that these drugs are accomplishing, as well as just the diet and gastric and endocrine things they're doing. And here are some human studies that show the same thing, immune moderating effects. So what is a natural to come out of this? Well, one of them is going to be that we're beginning studies where we're going to combine one of our traditional immune moderating medicines, like an interleukin-17 inhibitor, along with one of these drugs, and see if, in comparing that to the interleukin-17 inhibitor alone, whether there's better results in our diseases like psoriatic arthritis and psoriasis. And here's a single case study that I found using the one called semaglutide. And in this particular patient had been on a TNF inhibitor, I think it was adalimumab. They had been on an interleukin-17 inhibitor. They had had benefit for their psoriatic arthritis and psoriasis, but then lost benefit and were on no immune moderating medicines. They went on this drug semaglutide, and look, just with semaglutide alone, they were able to improve their psoriatic arthritis. They lost weight, their skin scores improved, the PASI score, their DAPSA score, which is a measure of tender and swollen joints, improved, and their CRP, an inflammation marker, went down. Now, I'm not recommending that you stop your immune moderating medicine and go out and get one of these drugs. This may be a fluke that this person had such a striking response, but it certainly supports the notion of, one, weight loss, and two, in order to treat your condition, and two, the possibility of using one of these medicines if they become approved and more affordable for use. Some of the side effects, nausea and vomiting, if you eat too much, that makes sense. They're given as an injection, so they can have injection site reactions and so on. So this is my last slide, and I've already made all of these points. So I'll stop there and turn the meeting back over to John and Jen to help moderate where we go from here.
Thank you so much, Dr. Mease, for this really insightful presentation. And I do really like how you included GLP-1s. I'm sure it's on top of a lot of our minds. I've gotten a couple questions just to me, so I'll ask those. John will ask the questions in the chat. In the meantime, if any of you have questions, please enter them in the chat as we go through them one by one. And Dr. Mease has gracefully agreed to stay on a little bit longer so that he can answer all your questions. So my first question from a patient is, he's very concerned. He's been diagnosed with PsA. His pneumatologist also think he might have psoriasis, but right now he's having a lot of pain. It says his spine surgeon says there's fusing in the spine to prevent rotation of the neck. Think he might have scoliosis. His right scapular and shoulder pain is pretty unbearable. Sitting is worse on really bad nerve pain. He's wondering if there's anything you can recommend to deal with pain and non-surgical spine straightening.
Oh, was the last phrase non-surgical spine straightening?
That's right. I think that's what his
okay.
neurosurgeon want him to do.
So the first comment to make is that, of course, physical therapy can be done, and I suspect he's already been involved with physical therapy to try to improve alignment of the spine as much as possible. But in all truthfulness, there's not a lot that can be done if he already has ankylosis from psoriatic arthritis and scoliosis, which is a gradual curvature of the spine rather than it being straight up and down, which people tend to have as either genetically or congenitally determined. So there's not a lot we can do for straightening other than following physical therapist advice about doing home exercises to maintain as straight a posture as possible. I'm assuming that, well, let's not assume. If there is an element of inflammation in the spine contributing to pain, then that can be, one of the ways in which we diagnose that is by using MRI scanning and looking for light up in the bone of the spine. And that helps confirm that there's inflammation present. And if it is, and the person is already on, say, a TNF inhibitor or their second or third TNF inhibitor, then what I would be doing is this is inadequately treated inflammation contributing to the pain, and therefore we should switch medications to an IL-17 inhibitor or a JAK inhibitor if they haven't been on that before. In terms of mechanical or degenerative arthritis pain, that's not going to be touched by one of our immune moderating medicines. So then we depend upon, if physical therapy isn't helping adequately, then we depend on medications. So what are the medicines that you can use? Well, there's simple Tylenol and anti-inflammatory medicines, but undoubtedly this person has already used those and not gotten meaningful benefit from them. There are now more medicines that are out there which are not narcotic medications, but can achieve pain improvement. Why do I try to have a person steer away from narcotic pain medicines? The reason is that there is something called opioid-induced hyperalgesia. Opioid-induced hyperalgesia. This is where, if you are constantly taking narcotic pain medications, it changes the receptor number and function. And the pain-related nerves no longer can respond to whatever dose of opioid medicine you're using, and you have to ramp it up in order to saturate the various receptors in the neurons of the central nervous system and the peripheral nervous system. Again, we call this opioid-induced hyperalgesia. So how do we get around that? We don't use opioids. And instead we use, let's say, a serotonin and norepinephrine reuptake inhibitor. What are those? They're medicines that boost serotonin and norepinephrine in the central nervous system. And especially the norepinephrine part of the boosting is a analgesic medicine approach. It boosts a certain aspect of the central nervous system so that there's less pain experienced. And an example of that type of medicine is something called duloxetine. That's the generic name. And the trade name is called Cymbalta. And this is a medicine that's typically taken in the morning once a day, 60 milligrams. There are others that are in that same category, one called milnacipran, for example. Then there are medicines that help reduce the nociceptive signaling into the brain. And one of those is gabapentin. Another one is pregabalin. And these are medicines which can be used in conjunction with the SNRI medications that I've just described to try to yield pain improvement. Then there are other approaches, for example, acupuncture. And the way acupuncture works is the same way that the serotonin and norepinephrine reuptake inhibitors work. It works in this descending or pain relieving part of the nervous system. So we see some of the same kind of chemical changes in the brain and spinal cord caused by acupuncture as we do by these various medicines that we're using. Some people will try things like CBD that you take either orally or under the tongue, or you can inhale CBD. This may have an analgesic effect in some people. And then and a lot of this is directed toward the mechanical fact that you've got scoliosis, as well as you've got these bridging syndesmophytes, it sounds like. I know that many spine surgeons are really nervous about working with people with meaningful scoliosis, partly because it's such a bear to try to go in and cut the bones and try to align them properly. And the recovery from that is really quite something. But if you haven't consulted more than at least one spine surgeon, I would certainly entertain seeing a second or third spine surgeon as well, to be sure there's not a reasonable surgical approach. Lastly, I'm going to mention injections. And at our center, we sometimes will have people get what's called epidural steroid injections. This is where either a interventional radiologist or a physiatrist will put in a little cortisone into the epidural space around these exiting nerve roots, or exiting from the spinal cord, where there's a lot of pain that occurs. Sorry, I didn't mean to be that long, but that's
Thank you. I'm sure the patient is really appreciative of that really comprehensive answer. I just have one more on my end, and then I'll switch to John. So feel free to put in questions in the chat, rest of you on the call. So this is a patient who's wondering about the decreasing effectiveness of TNFi if used long term. So specifically, she's been using Symphony Aria, but her symptoms start to reappear after 6 weeks after infusion and 2 weeks before the next scheduled 8-week infusion. She's wondering, will this increase in symptom toward the end of each cycle contribute to building up tolerance to the drug and thus makes it less effective over the long run?
Yeah, right. So this is something that every week I'm working with someone like you, where with all of the medicines that we use, unfortunately, there tends to be a wearing off of effectiveness. And it comes in a couple of different ways. One is the way you've just described it, where at the very tail end of the treatment cycle, there's a week or two where the treatment is clearly not as efficacious. And the way we work with that is to try to shorten the dose interval. In the case of Symphony Aria, it would be to shorten it from 8 weeks to 6 weeks. How do we accomplish that? We accomplish it because the insurance companies are very strict about not allowing anything except once every 8-week dosing for the most part. Sometimes we can fight with the insurance company and get it to approve an every 6-week dosing. But the other way to do it is to give it every 6 weeks and then booster the amount that the person has gotten by using a sample that we have in the clinic. So we just give the person a sample, and by that means we can shorten the dose interval. So when a person is having the experience you described, we still try to run with Symphony as long as we can, since at least 6 weeks is good. And then we try to do the maneuver that I've just mentioned to give them a little bit more and more frequently. Eventually, unfortunately, there will come a time when you'll say, it's just not doing, even in the 6 weeks that I get good benefit, it's not going to, doesn't work well enough. And then we have to switch to a different medicine, either another TNF inhibitor or to a different class, like an IL-17 or JAK inhibitor. This is just, unfortunately, the way it is. And sometimes it's related to the body developing antibodies against the drug that's infused or injected. Other times it's just because the immune system figures out how to do an end run around the medication. And so it's very common for us to eventually need to cycle or switch to a different medication. That's one of the reasons why we're so eager to have new medicines being approved because of this phenomenon.
Thank you. John, you want to go through the chat?
Yeah, great. Dr. Mease, I have to say, there's no less than a ton of information here. As usual, I feel like I need to take it and study it because there's an incredible amount of stuff to digest here. But anyway, really great. Thank you. First question is from Susan. I have been on Remicade, Inflectra for AS, and inflamed colon for over 10 years. Going to try to change to Simba, but insurance wants me to try something else. Not uncommon. Humira failed before Remicade. What are your thoughts?
I'm not sure what Simba is referring to.
Simzia.
Oh, Cimzia. Okay.
Cimzia. Sorry.
That's fine. So Cimzia is certolizumab. And certolizumab has a special place, by the way. It doesn't cross the placenta. So we like certolizumab in young women who are either contemplating getting pregnant or have just become pregnant. We will sometimes switch them to certolizumab from whatever TNF inhibitor they're on, because we know it doesn't cross the placenta, nor does it cross through breast milk. So it's absolutely safe in pregnancy, and the FDA has deemed it such. As the 5th TNF inhibitor to be approved, it is furthest back on insurance company formularies. The certolizumab company isn't able to give the formulary managers the kinds of rebates and discounts that the AbbVie people who have Humira, for example. And so it's not uncommon to hear them coming back and saying, oh, certolizumab is just a little too expensive for us. You need to try a different medicine instead. And so what we end up doing is looking at that response. And if the response is not unreasonable, then we say, well, let's do it. Let's go with what they will approve and not hassle it. But if, for example, the person is wanting to get pregnant and we want to switch to certolizumab, then we come back to the insurance company and say, well, if there's a problem with the pregnancy, it's on your head. And so they very quickly will approve certolizumab in that circumstance. But let's say you're not planning to get pregnant, then all you can do is either A, accept what the insurance company says, or B, have your practitioner go to bat for you. And sometimes that means getting on the phone with a physician employed by the insurance company to deal with such calls. And we often find that the physician on the other end of the line will cave if we are insistent enough, and they will end up approving the switch. But doing that takes time and energy on the part of your practitioner, your doctor or nurse practitioner, and so you can't always count on them to be willing to do that.
Thank you. That's excellent answer. I have a question here. What are the newest, most effective treatment therapies and DMARDs to halt AxSpA progression other than TNF, IL-17, and JAK inhibitors? Is APREMILAST effective for anthesis?
So apremilast is not effective for the spine. It was tested in a phase 3 ankylosing spondylitis trial and did not show benefit compared to placebo. It is effective for peripheral entheses, like Achilles tendon or plantar fascia or around the knee and so on, but it doesn't appear to work in the spine. So it is not a medicine that we would typically pull out of our hat to try for spine-related symptoms. Unfortunately, we don't have a class of medicine other than TNF, IL-17, and JAK inhibitors to use. But as I mentioned, there's this new IL-17A and F inhibitor known as bimekizumab that is going to be approved. I think it was supposed to either occur today or next Friday by the FDA for AxSPA. And so we are going to be, even in patients that have tried Taltz and Cosentyx before and eventually failed them, we are going to be prescribing bimekizumab as a trial for those patients as the next drug that has shown benefit.
Great. Steve from our Seattle group asks, can you explain the difference between psoriasis and psoriatic arthritis?
Psoriasis is the skin disease, and some would lump nail disease into that. As mentioned, psoriasis occurs in 3% of the population. Psoriatic arthritis is the form of arthritis, enthesitis, dactylitis, and spondylitis that occurs in people with psoriasis. So about 30% of people with psoriasis will ultimately develop psoriatic arthritis, so the musculoskeletal inflammation. It's extremely rare, 1 out of gazillion, where we'll have a person who has all the clinical features of psoriatic arthritis, but no psoriasis. It's also fairly rare for the psoriatic arthritis to come on first before psoriasis, but it can occasionally happen that way.
Thank you. Question from Kathleen. I don't quite understand, Kathleen, but this says GRAPPA, GRAPPA 2024 expected. Does that make sense? GRAPPA.
I think maybe asking about treatment guidelines expected in 2024.
Possibly, yeah.
So we've just started working on the next round, and we anticipate that it will be completed and published at the tail end of 2025 or the beginning of 2026, just in case that's what you were asking about.
Great, thank you. Okay, next question. What is the typical treatment for inverse psoriasis?
So with all humility, I'm not a dermatologist. All the medicines that we have gotten approved for plaque psoriasis, that sort of scaly, red, raised condition that we find on the skin, it can occur in the underneath the armpits, in the skin folds of the groin, underneath the breast. and this is called inverse psoriasis. And it looks different than typical plaque psoriasis, like on an elbow or and so on, because it doesn't have as much scale. It's red and it's irritated and it's itchy, but it doesn't have nearly as much scale as the more surface type of psoriasis. And all the treatments that we use for surface psoriasis are effective in treating inverse psoriasis.
All right, thank you. This question is, will the last new RX in parens semi, SEMI, maybe that's a drug name, I don't know, be available for infusion in the near future? Says last new RX SEMI. Not sure.
I'm thinking that he's referring to semaglutide, which was the weight loss drug. Wegovy and what was the other one? To my knowledge, they're all subcutaneously administered, and I'm not aware enough of them or familiar enough with the various versions of these medicines to know if any are intravenously available. Both the questioner and I will have to go to Google, to our ChatGPT, and ask the question.
Great, thank you. Okay.
Sounds like Jen will probably ask ChatGPT before we're done with it.
High likelihood. Sophie asked, B27 positive with severe neck damage, along with torn labrum and tendons all over, also ANA positive. How does that lead to an AS diagnosis as opposed to other autoimmunes?
Right. So what's the fly in the ointment here is her ANA positivity. ANA stands for anti-nuclear antibody. So there's an array of blood tests that we do in rheumatology. When the person comes in with joint pain, fatigue, and so on, and we're just doing a shotgun blast to check different things. So we do rheumatoid factor, CCP antibody, which is cyclic citrullinated peptide antibody. We do anti-nuclear antibody and all the family members of the ANA and so on. So if the person has classic clinical features of either axial spondyloarthritis or psoriatic arthritis, we just call it that. We know that it is based on physical exam, history, X-ray, MRI scan, etc. If they happen to have a positive ANA, but no other manifestations of lupus or Sjogren's syndrome, which is dryness of the eyes and mouth, then we'll say this ANA is there. It's a red herring. It's there, but it's meaningless. And sometimes I will say to a person, a patient, to illustrate this, I'll say, well, let's say if we set up a lemonade stand on the street outside of our clinic, and we gave a free glass of lemonade to the next 100 women who walk by the lemonade stand in order to be able to have a sample of their blood and then run an ANA blood test, we would find that something like 10 of those people would have a positive ANA.
Wow.
Of those 10, either 0 will have any disease that goes along with it, or maybe 1 person will have some symptoms or signs of a disease that goes along with it. So ANA positivity is kind of the bane of our existence because it is frequently present but may not mean anything. And so we have to sort out by asking questions, doing a physical exam, getting other laboratory features like urine sample and so on, to discern whether or not there's any disease that may be present as part of this ANA being positive. Now, having said, and many of the times it's a red herring and we just ignore it. So, but I appreciate that the patient is left with worry. Is this going to be an issue for me? So here's one way in which the person has classic axial spondyloarthritis and a positive ANA where we might change our behavior a little bit. And one of them is, we know that on extremely rare occasion, extremely rare, TNF inhibitors can cause a false elevation of anti-nuclear antibody. And so we will sometimes avoid use of a TNF inhibitor if we feel that the person is a positive ANA and might convert to having some manifestations of lupus. The other situation we find ourselves in is having overlap syndromes. So on rare occasion, a person can have some elements of lupus, but also have elements of psoriatic arthritis or axial spondyloarthritis. Not common by any means, but sometimes it is. And then we'll end up treating both. We'll give hydroxychloroquine or similar medicine for treatment of lupus manifestations, and we'll give an IL-17 inhibitor, but not a TNF inhibitor, to treat the axial spondyloarthritis or psoriatic arthritis part of it.
Thank you, Dr. Mease. I'm going to back up on the question we had before about, will the last new RX, in parentheses, SMI, be available for infusion? You said Jen will probably look it up. Well, Jen looked it up, and here's her response. Both drugs come as pre-filled injection pens, but Ozempic pens contain multiple doses of the medication, while Wegovy pens contain a single dose. Can't find anything in infusion form yet. There's apparently a pill form. So that's from Jen on that.
Okay. Thanks, Jen.
Are GRAPPA members conducting clinical trials? How can I get involved in CT running in Southern Cal? I'm not sure GRAPPA members. Jen, you know, GR.
So GRAPPA members certainly are, again, there are probably around 1,300 GRAPPA members around the world.
Okay.
A certain percentage of them in their clinics are involved in doing clinical trials. And generally in a region, if a rheumatology practice or dermatology practice is involved in doing clinical trials, there are ways of figuring that out. Word of mouth, obviously. It's possible that the clinic's website is indicating whether or not they do clinical trials or not. I think our website does indicate that. If it's a university clinic, they're probably doing clinical trials, but that's certainly not a guarantee. And then the other is by going to a system called FDA.gov. FDA.gov. And on that system are listed all the clinical trials, and they'll list them by disease state and by type of treatment. And there will be a listing of a way of getting to a part of the website where you can see if there are centers in your region that are conducting a trial with this or that medication. So those are a couple of tools for ascertaining whether or not a clinical practice is doing clinical trials. Doing clinical trials is arduous. Takes a lot of, it's bureaucratic. Over the years, there have been many times when I've questioned continuing to do clinical trials, but because it's so much time and effort. And what's frustrating to many patients is they come in to be evaluated for a trial, and then they're told, nope, sorry, you've been on too many medications to be eligible for this trial, because many companies don't want a person who's been on 10 different medications. They may be harder to treat than a person who's been on one medication previously. And so there's all these enrollment criteria for the study, which the person may not fulfill. Some studies, for example, prefer to enroll patients who have had no previous exposure to a biologic medication. So that's going to rule out a whole bunch of people on this call. But some trials are just terrific, and I will say that some of the current work that we're doing with, for example, deucravacitinib, or there's a new another TYK2 inhibitor that we're doing clinical trial in. So there are some emerging trials that I think are going to be very helpful for the patient.
Thank you. So I just was wondering about a time check here. We're at 4:17. I got a note from Jen, and she said, if people are good and we got questions, why don't we go until 4:30, and then we'll kind of close out.
Sounds good. Sounds good to me.
There's a shout out to Dr. Mease. The book by Dr. Mease about axial spondyloarthritis is extremely clear and well written and researched. Highly recommended. So great.
Good. By the way, I get no what do you call it, royalties from that.
Wow. Sounds like you should have. What area of study is Dr. Mease most intrigued with today? Would you say psoriasis?
Well, there's several. I've in recent time I've gotten very interested in the obesity issue because of the success of these new medicines. They come with a price. They're expensive. You have to continue them, it appears, to maintain the weight loss. And so it's not a slam dunk. And frankly, there's equity and political justice, so to speak, issues, because if you don't have the fund, many people pay for these drugs out of their pocket, and only a small fraction of the population can do that. But on the other hand, there's the science behind them is really good, and in my opinion, the benefit risk ratio is very high on the benefit side relative to any potential risk. So that's and I'm fascinated by their potential immunomodulatory effects. So this is an area that we're going to be definitely studying quite a bit, and I'm already, developing lectures to teach people about the phenomenon. The other thing that I'm quite interested in, and I'm doing research at the moment, is sex difference in disease state and treatment response. There are some evidence that women may express the disease more to a greater extent symptomatically, and may not respond as well symptomatically to some of our treatments. Some of that may be immunology differences between males and females. Some of it may be sex hormone differences between males and females. Some of it may be pain sensitivity issues, and so on. So Lihi Eder, who is a researcher at the University of Toronto, and I are doing two different studies related to this. One is what I call more of a biologic study, where we're doing lots of blood testing. and as well as giving patients questionnaires and seeing how they respond to treatments that they're starting. And then the other is we're about to start a project where we're inviting people to participate who live locally here in Seattle to participate in focus groups. And we're going to try to listen. We have a medical anthropologist that we work with, and we're going to be listening to differences in the way men and women articulate about their disease and about their daily experience of it. And then at the end of the study, after the study is over and analyzed, and we have word clouds and all this stuff that comes from qualitative research, we're going to invite the two sexes to come together and hear the results and then have a discussion about it. So that's going to be a particularly fun bit of research to do. I'm also working with some of the newer treatments like deucravacitinib, this new Takeda TYK2 inhibitor. There's a fascinating new interleukin 17A and F inhibitor called sonelokimab, which is a nanobody. It's a very small molecular weight medication that's injected, but its small molecular weight may mean that it gets into tiny places better, or difficult places like Achilles tendon insertions. So we're experimenting with new medicines. And then I am also branching out and including in my research patients with other conditions like lupus, scleroderma, myositis. And we're using this really incredibly interesting new treatment approach called CAR T cell therapy, where we're using genetically engineered T lymphocytes, either the patient's own T lymphocytes or a healthy donor T lymphocytes, genetically engineered to become therapeutic cells that go around in the body and get rid of pathogenic cells, which are then replaced by non-pathogenic cells. So we're very much involved in that research at the moment. And we're the only site in the Northwest currently doing this particular work. However, I should mention that it's not that kind of cell therapy work has not quite reached in this country into PsA or axial spondyloarthritis. There's a fascinating treatment approach that was conducted in Russia using targeting TRBV9 T lymphocytes, which represent about 4% of the T lymphocytes of AxSPA patients. And when these cells were deleted, the patients did much better. And so I'm consulting with a company to develop what's called a T cell engager aimed at TRBV9 cells. So we're in the very, very early stages of aiming at that target in axial SPA.
Wow. Dr. Mease, you're an amazing resource on this, and we'll never let you go.
Okay.
When a person reaches advanced stage of AS, can biologics still slow the progression of the disease in regards to brittle bones?
That's really a good question. Thanks for asking that. So two comments to make. One is, even when a person has complete ankylosis, they may still have immune cells in their bones and joints that are causing pain and stiffness. So there can be symptomatic improvement of pain and stiffness with use of immune moderating drugs, even if there's no improvement in motion, in physical motion. So so there's still some potential value in using our drugs in advanced stages of disease. Another issue that is present in people with both psoriatic arthritis and axial spondyloarthritis is they can get osteoporosis. That seems paradoxical, since the disease is characterized by progressive ossification. So you'd think that if anything, the bones are getting more solid, but that's not the case. In fact, it's the other way around. And there's a little bit of evidence that use of immunomodulatory medicines, along with anti-osteoporosis drugs, can potentially benefit bone health in people.
I'm going to tag on a question here, if I may, and that is, basically what we're talking about here mostly is active AS, active psoriasis, using biologics and all of that to kind of keep at bay. Dr. Mease, how often do you see, after somebody's had this for 40 years, that active inflammation just starts to decrease
For sure.
on its own?
For sure. Absolutely. There's a natural tendency in many people for the inflammation to diminish and even resolve. So there's some people that we are working with who have used biologic medicines for 15, 20 years and now no longer.
So it just is a roll of the dice.
Right. I can't tell a priori for whom that's going to happen or exactly when, but we all the time we get the question, can I try without my Enbrel, or can I try without my Cosentyx? And sure, yeah, I'm all for it if the person is game.
Awesome. Somebody asked, can we get the name of Dr. Meese's book again? I recommend, Jen, that we send it out. Should we do that? Oh, here it is. Jen.
Yeah, I'll put the link in.
Oh, fantastic.
Yeah, I think like John was mentioning, we could keep Dr. Mease here all day long. He is a busy researcher, doctor. So with that, please join me to thank Dr. Mease for his time today. We will invite him back in a few more months. As you can tell, every time Dr. Mease come in, he just full of wealth of knowledge and updated news. So thank you again, Dr. Mease, for doing this, and me and I'm sure everyone here are super thankful. Thank you so much for everything you do.
Thank you for